go over fetal monitoring, and this is especially important is the part about fetal heart rate monitoring, which is the standard of care and done in pretty much all laboring patients in the hospital. So understanding that and how to look at those tracings is very important, both for sort of in the clinical setting and also just for as a general understanding about what's going on. Then we'll cover some more definitions and how to do some other types of fetal monitoring as well. So for our disclaimers, just health information, it's things to think about. It's not for treating yourself or for anyone else, so make sure if you have a problem you see a medical person. All right, so continuous fetal heart rate monitoring. Like I said before, this is essentially the standard of care when you come into the hospital and you're in labor. You get started on fetal heart rate monitoring, and what it is it's all externally done, so it's non-invasive, and there's a machine, it's sort of like a belt that you wear, that the patient wears, and it measures the fetal heart rate and also measures contraction. So it's an external tokometer as well as the fetal heart rate monitor. So the heart rate monitor does what it says. It just gives you heart rate in beats per minute, and the external tokometer measures contractions. It doesn't really give you good absolute numbers in the sense of, this contraction's bigger than that, or this person's having stronger than the other person, but it tells you when they're happening and how long they're going on for. So external tokometer tells you you're having contractions every 5 minutes. They're lasting for about a minute or something like that. All right, and so we're going to go through this table that shows all the different categories of what you can get from a fetal heart rate tracing. Just to go see what we're talking about here. The outputs essentially look like this. You're going to have the fetal heart rate tracing going like this. You'll have a little line with the heart rate bouncing around, and then you'll have the external tokometer down here showing that you've had a contraction, and it'll say the pressure went up, and then it leveled off and went back down to normal. All right, so the first variable that you look at in fetal heart rate monitoring is what is the baseline. All right, and so if it's less than 110, then you have fetal bradycardia. And essentially everything on this list, hypoxia is the first thing that you think about. So if you have less than 110, you fetal bradycardia, then the first thing you think about is hypoxia. But it also could be a congenital problem. If you have greater than 160, then you're thinking about fetal tachycardia. Again, the first thing you think about, hypoxia. Other things are fetal anemia. A classic pattern that you should be aware about for fetal anemia is also called the sinusoidal pattern. And so if you see a pattern like this on fetal heart rate tracing, just like sine waves going up and down, that should make you think about fetal anemia as well. So then moving along to variability, normal variability is between 5 and 25 beats per minute. If you have less than 5 beats per minute of variability, then you're either in the absent variability or minimal variability category. So less than 3 is essentially absent variability. So that's a very significant problem when you think about severe fetal distress or hypoxia. And if you're minimal variability, you have a little bit, greater than 3, but less than 5. And things that you can think about with fetal hypoxia could be fairly benign things like sleep, or it could also be hypoxia, as always, or opioids or magnesium if you have preeclamptic patient on magnesium. So we're talking about variabilities. You see the tracing here. Then you're going to have some bouncing around going along, right? And you should see some of that. That's normal. And then you can see here you have the beats per minute on the y-axis. Beats per minute on the y-axis and some variability. So minimal or absent variability, you'd be seeing a very flat line without the little zigzags. All right, and marked variability, hypoxia again comes up, and the idea is, or one way to think about it is that you have, it's like getting thrown off a bridge into some water or something. At first, you kind of thrash around a lot, so that'd be increased variability, and then that progresses to minimal or absent variability as it gets more severe. All right, so accelerations, that's another thing you look for. So an acceleration is greater than 15 beat per minute increase over 15-second period. And if you have 2 of these in a 20-minute period, then you call the test officially reactive. It's a reactive test. And that's these categories of the 15 seconds and 15 beats per minute are for over 32 weeks. If you're less than that, then you use a 10 beat per minute cutoff and a 10-second cutoff. And so we're talking about acceleration. You see your heart rate zigzagging along, and then it goes up a little bit, and then it comes back down to wherever the baseline is. That's what an acceleration is. All right, so decelerations, this is sort of the big category here. It's almost the meat of this whole talk. And so there's different types of decelerations, and we're going to go through the different types. And the thing to remember about decelerations is that's why it's so important to have the external tokometer data, because categorizing these things depends on what's going on with the contractions. All right, so we'll start out here by just drawing our little graphs, and so you have a contraction going on, and then you're going to look and see what the fetal heart rate's doing during contraction. So we're going to start off with the first type of deceleration, which is here, and this is all the normal. This is like the normal data. So the early deceleration is the normal one. So what that is, you have your heart rate bouncing around. The contraction starts. The heart rate goes down a little bit. The contraction gets past its peak, and the heart rate goes back up. So as you can see here, the contraction, the early deceleration, is like the opposite of the contraction. So it's like a mirror image. Okay, it's like if you folded them, they would line up with each other. This goes up and this goes down. This early deceleration is just a normal thing. The idea, like pathophys, way to think about it is you have contraction. It's compression on the fetal head. It causes like a vagal type response, and you have some little drop in heart rate, and it comes back up. And if you look at when the deceleration starts till when it gets to its nadir, that's greater than 30-second period. And so we're going to contrast these early decelerations to another type of deceleration. This is called the variable deceleration. So a variable deceleration, you're going along, and it can happen sort of any time during the beginning, middle, and part of the contraction. But you're going along with your fetal heart rate here, and you drop down, and then bounce back up, or it could be here that you drop down, or it could be here at the end. So variable refers to the variability of when it starts. Doesn't necessarily start early here or late. It can start sort of at any time. But the distinguishing feature about a variable deceleration is the time from when it starts to when it gets to the nadir is less than 30 seconds. So we said here it's greater than 30 seconds. That's a very sort of gentle sloping gradual decrease. Variable deceleration is not that. Variable deceleration is more of an abrupt spike down sort of picture. And the pathophys or etiology thing you think about with variable decelerations is cord compression. So variable deceleration, you think about cord compression. All right, so now we're going to move on to the third type that we want to just draw and understand what it looks like a little bit, and that is the late deceleration. So late deceleration, you're going along like here, and then you get to the peak of contraction on the external tokometer. So you're there past the peak, and then you start to have your deceleration. It goes along, and it slowly kind of comes back after the contraction ends. Right, so you can kind of see how that's different from when early starts right when the contraction starts. This doesn't start until later on, and then it takes a while to bounce back. And again, like an early contraction, it takes greater than 30 seconds to get from when it starts to decrease down to the nadir. So it's also a gradual, slow, not the abrupt picture like we saw there with the variables. So late deceleration, the thing to think about with regards to etiology in this is uteroplacental insufficiency or fetal hypoxia. All right, and so we'll talk about the management of these things. So just to get rid of early right away, early is normal, so you don't have to manage early. It's a normal finding. And so we'll talk about managing variables. So variable, the reflex thing you think about is something cord compression issue for the etiology. Things you can do to try to manage this are change position, so Trendelenburg position, to give that a try. Give oxygen by face mask. You could stop giving oxytocin. You can also check, because this is a potential cord issue, that if there's a cord prolapse or if there's imminent delivery about to happen, you can look on exam to see if those things are happening, and can consider an amnio transfusion to maybe take some of that pressure off the cord. All right, so late decelerations, you can try in the etiology. Think about there's fetal hypoxia and uteroplacental insufficiency. So you can try some of the same things you tried that you do for variables. So these are like the standard things. You can change positioning, give oxygen, and stop oxytocin. Those are things you can do for both of these as your initial attempt. But with late decelerations, you have to remember that these are sort of like the bad ones. All right. So if late decelerations continue happening and it's been greater than 30 minutes, you can decide maybe to check a scalp pH. If it's less than 7.2, that would say this is a very acidotic fetus and things aren't going well, and you need to do an imminent delivery. Or you could also see if that you have the late decelerations going on, and then you look at the tracing and you say now that this has been going on for a while, now we have minimal or we have absent variability in addition to these decelerations. That would be another indication for saying we need to deliver now. We need to do imminent delivery. All right, so I think we've talked about those and understand the different types of decelerations fairly well. I just want to mention one more thing about the tokometer, external tokometer, before we move on. And that, so it's used for figuring out what type of deceleration you have and looking at the matchup between the heart rate and deceleration. But it can also tell you stuff about contractions themselves. So it can, if you see a lot of contractions, for example, greater than 5 contractions in 10 minutes, then you can identify or diagnose a problem called tachysystole. So tachysystole doesn't have to do with heart rate, or even though it kind of sounds like it does in this situation, it's talking about too much contractions. Greater than 5 in 10 minutes, you could identify that. And also you can see hypertonus, that's contractions lasting longer than 2 minutes. If they're lasting for a really long time, that can be a problem. You can see that using the tokometer as well. All right, so we're going to move on here, and so once you've gotten that data about the fetal heart rate tracing, then you use that to put it into a category. Okay, so category 1 is normal. So what would normal be? A baseline between 110 and 160. So a baseline of 140, let's say, that's normal. Variability is moderate. It's bouncing around 10 or 15 beat per minute variability you're seeing. And the only deceleration you're seeing are early, so it's essentially totally normal. And then you go down to category 3, and you say, so okay, something definitely is not normal here. Maybe you should get somebody if you saw the tracing that you were concerned was category 3. All right, so what do you see there? Would be absent variability with bradycardia or variable or late decelerations, as well as a sinusoidal patterns. This is certainly sort of a big-time problem tracing. Then you have category 2, which is a fairly common finding, and it's not exactly perfect like category 1, but it's also not category 3. And that's the way to decide which tracing what you're seeing falls under. Right? So it's either 1, perfectly normal, 3, definitely a problem going on, and do really look at the variability. And if it's not there, then you're essentially in category 3, or if you have anything else, any other problems, you're in category 3 along with it. And then if it's not 1 or 3, category 2. Okay, and so where does this come up? It comes up with the progress notes that either you or some other people on your team are writing about these patients. So you should be checking the fetal heart rate tracing fairly frequently. So in the first stage of labor, check it about every 30 minutes. The second stage, you can check it every 15 minutes. And then you incorporate that into a note, which you write Q4 for people in latent labor. Remember, latent labor is from 0 up to 4 centimeters, can take up to 20 hours, and people who haven't had kids. And then you do it more frequently in Q2 when people who are in active labor. So as you can see here in the note, you start out with how's mom doing? The 4 standard questions you ask everybody. Then you do vitals for mom. Then you do the vitals. Fetal heart rate tracing is like the vitals for the baby. So how's the baseline variability or accelerations? You say accelerations present. If there's decelerations, you could say early decelerations only or something like that. Or you could say variable decelerations, late decelerations after greater than 50% of the contractions. All right, so you put the fetal heart rate tracing there. And then here when we're talking about the plan, you could say the fetal well-being here is reassuring with a category 1 tracing. All right, so that's that. And so that's the media's talk. Now we're just going to go through some other things to look at or that can be looked at to help assess the fetus either during labor or antenatally, prenatally. All right, so scalp pH and monitoring. So scalp pH, you have to get a little bit of blood to do this. You can measure the pH, measure lactic acid. It can help you decide how imminent or big a problem is. I don't think that this is used very frequently. Scalp monitoring is like an electrode. You can do pulse oximetry, so you can get an EKG and heart rate monitoring for that. And IUPC is intrauterine pressure catheter. So the intrauterine pressure catheter is different than the external tokometer. So you're actually putting a little catheter past the presenting part of the fetus into the uterus, and you're getting real like absolute numbers, so you can say how strong are these contractions. And they use this unit called Montevideo unit, and it's a transformations of the pressure changes along with factoring in how frequently they are in time, and it gives you strength of contraction sort of unit that you might come across. All right. All right, so that's different than the external tokometer in terms of you get real numbers. I can say these contractions are more than these other ones. And so the non-stress test, this is very common antenatal test if there's any concern for something going wrong, maybe intrauterine growth restriction or maybe not feeling the baby move or something. This is a way to evaluate what's going on. And so you have to do this after 26 to 28 weeks because you need the nervous system to be matured so you can have reactivity. And what a non-stress test is essentially what you're doing in the hospital with the fetal monitoring. You're looking at how the heart rate's changing around over time. and but you're just doing it um, in the outpatient setting, and there probably aren't contractions happening. All right, so you do non-stress test. What the normal or reassuring result is a reactive result. So it's 2 accelerations, just as we defined before, greater than 15 beat per minute increase in 20 minutes. And if it's less than 32 weeks, you drop it down to a 10 beat per minute increase. So that's a reactive test. You have greater than 2 of those, and that's reassuring sign. So if you don't, then you're in the non-reactive category, and it's not as reassuring. You can do something called vibroacoustic stimulation. So it's sort of sound and waves to maybe stimulate, maybe to move around a little bit more, and that can help maybe take a test from being non-reactive to reactive, so that you don't have to do any more testing. But if the vibroacoustic stimulation doesn't do it, you need to continue to evaluate what's going on, and you move on to a biophysical profile, which we'll talk about in a little bit. All right, so a contraction stress test, in contrast to a non-stress test, is with contractions. So it's like an oxytocin challenge test. It's kind of like people who get a stress test for the heart. It's kind of the same type of thing. It's used later on in pregnancy, and you're going to try to use it to assess utero-placental dysfunction. So you give some oxytocin. You keep titrating that up until you get 3 or more contractions in 10 minutes, and then you are looking to see what do those contractions do to the fetal heart rate. So this is almost like simulating what's going to happen to the person when they come in labor. So if you have a positive contraction stress test, then that's non-reassuring. And so a positive contraction stress test is you're seeing what you'd hoped you wouldn't see when somebody's in labor. So what would those be? What type of decelerations are we talking about? We're talking about late decelerations following greater than 50% of the contractions, and that's what you don't want to see. And if you have a negative contraction stress test, then that's reassuring. So that's saying you're not seeing significant late or variable decelerations. All right. So the biophysical profile. This, if you've done the non-stress test and it's non-reactive, then you can do a biophysical profile to further assess that. So the biophysical profile has 5 different variables, and each of them can be scored 0 or 2, so you can get up to 10 points on this test. And so the first thing you do is you repeat a non-stress test. You don't use the old results from the old non-stress test. You do it again, and then you look at these other variables. So you do amniotic fluid index. So that's with an ultrasound machine, you're looking for pockets of amniotic fluid and divided up into the amniotic sacs, divided up into quadrants. You find the deepest pockets in those quadrants. You add them up and get a number. It's amniotic fluid index, and then it can be either 0 or 2, depending on the number that you get. You look for breathing. So if you have a rhythmic breathing episode, if you have movement, 2 movement episodes, and if you look at tone, and that's flexion and extension. Spine or limb flexion and extension is a way to look at tone. So you add all these things up, and you get a number. And so if you're 8 or 10, that's saying there's very minimal risk. And if you have less than 8, then that's fetal distress. So you can see you can only really miss one or 2 points there. All right. And so what we looked at were all measurements of fetal well-being, and there's other things that are important to look at. For example, lung maturity, sphingomyelin ratio, and things like that. And so we didn't talk about that here, but we're going to talk about that in a different talk here. So we just talked about we kind of stuck to the well-being sort of measurements. So I hope that clears up those different tests and how they work. And thank you for watching. Visit the website for more, and consider checking out 52kids.org and making a donation. Thanks again.